Hello and welcome back to the AEC Offline channel. Today, I'm going to be reading my entire 13-page autism diagnosis. I'm only going to censor information that will dox me. Nothing else. Now let's begin. Confidential Neuropsychological Evaluation Report. Gender, transgender female. Dates of evaluation, December 11th, 2025 and January 12th, 2026. Education, 12. Age, 19. Date of report, January 21st, 2026. Referral source, self. Reason for referral. Patient has previously participated in psychotherapy and psychiatric care. However, she is currently seeking comprehensive neuropsychological testing to clarify the underlying etiology of her presenting concerns. Formal evaluation is medically necessary to determine whether her symptoms are best accounted for by a neurodevelopmental condition, e.g. autism spectrum disorder or attention deficit hyperactivity disorder, or medical or neurological condition or primary psychiatric disorder, such as obsessive compulsive disorder, avoidant restrictive food intake disorder, or bipolar disorder. Neuropsychological assessment is required to inform accurate diagnosis, guide treatment planning, and ensure appropriate clinical and educational supports. Tests administered. Adult ADHD Self-Report Scale, ASRS-V 1.1. 2. Autism Spectrum Quotient, parentheses AQ. 3. Beck Anxiety Inventory. 4. Beck Depression Inventory -2. 5. Brief 2-A Self-Report. 6. Camouflaging Autistic Traits Questionnaire, CAT-Q. 7. Dennis Kaplan Executive Function System, Color-Word Interference, Trail-Making Test, Verbal Fluency. 8. Empathy Quotient. 9. MOXO. 10. Obsessive Compulsive Inventory Revised, OCI-R. 11. Personality Assessment Inventory. 12. Victoria Symptom Validity Test. 13. Wechsler Adult Intelligence Scale -5. 14. Wender Utah Rating Scale. 15. Wisconsin Card Sorting Test. Informed consent, potential risks and benefits, limits of confidentiality, and test procedures were discussed. Following this discussion, the patient agreed to complete the evaluation. Chief complaint. Patient is a 19-year-old transgender female referred for comprehensive neuropsychological evaluation to characterize current cognitive functioning, clarify diagnostic considerations, and inform treatment planning. Her referred name is, and her pronouns are she, her. These will be used throughout the remainder of this report for consistency and respect. Patient reports a long-standing history of developmental and emotional behavioral concerns, including early developmental delays, social communication difficulties, restricted interests, repetitive behaviors, motor coordination, challenges, and sensory processing sensitivities. She also endorses symptoms of depressed mood, irritability, and intrusive thoughts. Additionally, she describes periods of abnormality or persistently elevated, expansive, or irritable mood, accompanied by high-risk behaviors, decreased need for sleep, racing thoughts, distractibility, impulsiveness, difficulty following through on tasks, and avoidance of activities requiring sustained mental effort. Background history. History of presenting problem. Patient reports that her family has long suspected that she may be on the autism spectrum, in part due to a strong family history of autism spectrum disorder. Her mother, father, and 2 cousins have all received formal diagnoses. A previous therapist also reported strong suspicion for autism spectrum disorder. Patient describes long-standing sensory processing difficulties, particularly related to sound. Loud, high-pitched, rapid, or grating noises are especially distressing. During periods of significant sensory overload, she may need to physically remove herself from the environment and will curl up and shake as a means of self-regulation. She also reports engaging in repetitive behaviors until she can return to a prior task. Patient endorses additional sensory sensitivities, including intermittent light sensitivity, most notably when she's already overstimulated. She has significant tactile sensitivities, reporting that she is unable to wear denim and has previously cried when required to do so. Clothing tags are intolerable and must be removed. With regard to eating, she can consume a moderate range of foods, but reports greater difficulty with taste and texture. Her list of safe foods is highly restricted, includes peas, carrots, corn, and white rice, which she prepares frequently. Even with safe foods, if something feels wrong or off, she will be unable to eat it. A previous therapist raised the possibility of avoidant restrictive food intake disorder, RFID, though they indicated they were not qualified to make the diagnosis at the time. Socially, patient reports long-standing difficulty understanding social cues. She also describes becoming intensely fixated on specific interests for months at a time, to the extent that it becomes difficult for her to engage in activities outside of these interests. With respect to attention and executive functioning, patient reports symptoms consistent with inattentive presentation of ADHD. She experiences significant decision-making anxiety and difficulty following through on tasks she knows she needs to complete, particularly struggling with task initiation. She does not endorse prominent hyperactivity or frequent fidgeting, but rather describes low motivation and difficulty sustaining mental effort. Patient also reports significant obsessive compulsive obsessive compulsive symptoms, including intrusive thoughts and compulsions. Intrusive thoughts include unwanted, distressing thoughts of a pedophilic or incestuous nature, which she finds abhorrent and states she has no desire to act upon, as well as intrusive thoughts about causing a car accident while driving. She reports actively resisting these thoughts. In response, she engages in behaviors such as shaking her head to get the thoughts out, or eating a utensil and pressing against her skin in an attempt to associate the thoughts with pain. She also describes compulsive rituals that cause marked anxiety not completed, including striving to perform actions in sets of 4. For example, if she does not fully engage her car's turning signal, she feels compelled to activate a specific number of times to, quote, balance it out, driven by fear that something bad could happen otherwise. During the interview, she was observed bouncing her leg in sets of 4. Patient reports that numerous individuals who have known her for many years have expressed concern that she has become more radical and emotionally unstable in recent years and have encouraged her to seek evaluation. Upon reviewing past text messages, she acknowledges that she appears to have less social filtering than before, often making more charged and appropriate statements sometimes communicating in a more aggressive manner. She reports limited insight into these specific criteria underlining these concerns. Sleep has been chronically erratic. Patient describes periods lasting up to 2 months in which she sleeps from approximately 10 p.m. to 8 a.m., followed by periods in which she struggles to fall asleep until 2 to 3 a.m. and awakens early around 6 a.m. She reports feeling able to function during periods of reduced sleep, though she suspects it may negatively impact her mental health. She also notes that periods of decreased sleep may coincide with times of improved or elevated mood. She endorses episodes of elevated mood associated with impulsive behaviors, including excessive talking, impulsive activities, and impulse buying. Psychological history. Patient has always lived in hometown with her mother and father and has no siblings. She describes her childhood as generally normal. I'm just going to skip over this because most of this doxes me. Academically, she performed well, participating in enrichment programming in the first and second grade, and maintained by strong grades. She graduated high school in 2024 and completed 1 year at Purdue University, etc., etc. More doxing. Yeah. Mental health history. Patient is not currently engaged in therapy. She last participated in psychotherapy in 2023 for approximately 1.5 years. She reports experiencing passive suicidal ideation several years ago, around 2023. She was also treated by a psychiatrist through Conscientia Health, where she was diagnosed with anxiety and depression. She reports that she declined SSRI treatment, but believes she was misled to taking medication that she later learned was an SSRI. Trauma history, more doxing. Medical history, no significant medical history reported. Current medications, estradiol and spironolactone. Legal history, patient's driver license is presently suspended for 1 month following a traffic violation in which she was pulled over driving 102 miles per hour in a 55 miles per hour zone. Substance use history, no substance use reported. Behavioral observations. Patient was evaluated over the course of one session conducted on January 12, 2026. She arrived on time for the appointment and was appropriately dressed. Rapport was established and patient was cooperative through the evaluation. Effort and engagement appeared adequate across tasks, and there was no evidence of malingering or symptom exaggeration. Patient presented as alert and displayed normal speech with restrictive affect and congruent mood. Eye contact was inconsistent and overall reciprocity appeared awkward. Motor behavior was within normal limits and there were no signs of hyperactivity, impulsiveness, or tics. Expressive and receptive language appeared intact. Patient demonstrated adequate ability to understand test instructions and ask clarifying questions as needed. There were no issues noted with articulation, fluency, or verbal output. Patient approached tasks with variable focus and persistence. She required minimal redirection and responded promptly to instructions. Fatigue was evident, particularly upon tasks requiring sustained attention or effort over time. Patient exhibited appropriate frustration tolerance and emotional control. When faced with challenging tasks, she responded with perseverance. There were no signs of mood disturbance, anxiety, or behavioral dysregulation during the evaluation sessions. Performance was consistent across domains, and responses suggested a valid representation of current cognitive and emotional functioning. Patient did benefit from breaks and provided adequate insight to her own performance. Test results. The following section presents the results of neuropsychological evaluation. A comprehensive battery of standardized tests was administered to assess a range of cognitive and emotional functioning. These domains include intellectual ability, attention and executive functioning, memory, language, visuospatial skills, and processing speed, as well as emotional behavior and functioning. The findings are interpreted in the context of the individual's developmental history, clinical presentation, and reported concerns. Scores are described using standard scores and scaled tests unless otherwise noted. Neuropsychological and psychological effort. The Victoria Symptom Validity Test is a measure of mental effort on neuropsychological tasks. Patient's score of 24 out of 24 on the easy items, 22 out of 24 on the hard items, and 46 out of 48 on total items were in the valid range, indicating a good effort on the task. Patient had 0 out of 3 validity performance flags on the Moxo Attention Diagnosis Assessment, reflecting good effort. Therefore, patient's neuropsychological test profile is judged to yield an accurate and reliable reflection on her current neurocognitive capacities. Intellectual functions. The Wechsler Adult Intelligence Scale 5 is a comprehensive measure of adult intellectual functioning. Due to greater than 23-point discrepancy between index scores, the full scale IQ, FSIQ, is not considered a valid or meaningful summary of overall intellectual functioning, is therefore not interpreted. Accordingly, interpretation focuses on the individual index scores and pattern of cognitive strengths and weaknesses. Patient's performance on the WAIS-5 reflects a highly uneven cognitive profile, with marked strengths in verbal reasoning and more average performance across nonverbal and efficiency-based domains. Her verbal comprehension index was in the exceptionally high range, 133, 99th percentile rank, indicating very strong very strong verbal reasoning, abstract thinking, and word knowledge. Performance across subtests was consistently strong, with similarities in vocabulary both falling in the exceptionally high range, 90th percentile rank, suggesting well-developed verbal concept formation, expressive language skills, and access to crystallized knowledge. The visual spatial index fell in the average range, 103, 58th percentile rank. Performance on block design, 50th percentile rank, and visual puzzles, 63rd percentile rank, suggest intact visual construction and spatial reasoning abilities without evidence of significant weakness or exceptional strength in this area. The fluid reasoning index was in the high average range, 110, 75th percentile, reflecting solid ability to identify patterns and reason with novel information. Subtest performance showed some variability, with matrix reasoning in the average range, 63rd percentile rank, and figure weights in the high average range, 84th percentile rank, indicating stronger quantitative and deductive reasoning relative to abstract visual pattern analysis. Patient's working memory index also fell in the high average range, 112, 79th percentile rank, reflecting effective attention, mental manipulation, and short-term memory overall. Performance was variable across tasks, with digital sequencing in the high average range, 84th percentile rank, and running digits in the average range, 63rd percentile rank. Notably, digits forward was an area of exceptional strength, 98th percentile rank, suggesting very strong auditory attention span, while digits backward was average, 37th percentile rank, indicating relatively less efficiency with mental manipulation compared to simple attention. The processing speed index was in the average range, 102, 55th percentile rank. Performance on coding was average, 37th percentile rank, while simple search fell in the high average range, 75th percentile rank. This pattern suggests she generally has adequate visual scanning and graph motor speed, with somewhat stronger performance on tasks emphasizing visual discrimination over fine motor output. Attention and concentration. The MOXO Continuous Performance Test, MOXO CPT, is a computerized assessment designed to evaluate attention and related functions by simulating real-world distractors. Patients' performance on the MOXO suggests significant difficulties with sustained attention and response speed in the context of adequate impulse control and behavioral regulation. The attentiveness index fell in the weaker performance range, negative 1.36, indicating reduced consistency in detecting and responding to target stimuli over time. This pattern suggests that patient may experience difficulty sustaining attention, or resistance to, or resistance to distraction. The timeliness index was in the difficulty in performance range, negative 2.68, reflecting slowed response speed and reduced efficiency in reacting to stimuli. This finding suggests challenges with processing speed and timely responding, which may negatively impact patients' performance on tasks that are time-limited or require rapid decision-making. In contrast, the performance on impulsiveness, 0.47, and hyperreactivity, 0.31, fell within the good performance range. These results indicate that she demonstrates adequate inhibitory control and appropriate modulation of responses, with no evidence of excessive impulsivity or heightened reactivity to non-target stimuli. Executive functions, sequencing, and mental flexibility. The verbal fluency subtests of the D-KEFS assess verbal productivity and executive control of language across three conditions: letter fluency, category fluency, and category switching. Patients' performance on the verbal fluency task reflect strong verbal retrieval and lexical access with adequate cognitive flexibility and set shifting. On letter fluency, patient performed in the above average range, 91st percentile rank, indicating efficient phonemic word generation and strong strategic search of verbal memory. Performance on category fluency was similarly above the average, 91st percentile rank, reflecting well-developed semantic organization and rapid access to category-based lexical knowledge. Performance on switching fluency fell in the high average range, 75th percentile rank, suggesting good cognitive flexibility and the ability to shift efficiently between semantic categories under time constraints. The switching fluency total accurate switches score was in the average range, 50th percentile rank, indicating that while patient is able to shift appropriately between categories, The precision and consistency of switching were broadly age appropriate rather than the area of distinct strength. The why do I keep saying day? Jeez. The D-KEFS trail-making test assesses processing speed, visual scanning, sequencing, cognitive flexibility, and set shifting through 5 conditions: number sequencing, number-letter switching, switching distraction, switching working memory. These conditions increase in complexity, with switching conditions being the greatest demand on executive function, particularly cognitive flexibility. Patients' performance on the trail-making test reflects strong sequencing, visual scanning, cognitive flexibility, with relative variability under increased working memory demands. On number sequencing, patient performed in the above average range, 91st percentile rank, indicating efficient visual scanning and rapid numerical sequencing. Performance on letter sequencing was also above average, 95th percentile rank, reflecting strong alphabetical sequencing skills and sustained attention. Performance on number-letter switching fell in the above average range, 95th percentile rank, suggesting well-developed cognitive flexibility and the ability to shift efficiently between mental sets under time constraints. These results indicate that patient can manage complex sequencing and set shifting demands with speed and accuracy when attentional load is manageable. In contrast, performance on switching distraction was in the average range, 63rd percentile rank, indicating adequate ability to maintain set while filtering competing visual information. Performance on switching working memory was also average, 37th percentile rank, suggesting that efficiency declines somewhat when task demands require increased mental tracking and manipulation. Overall, this pattern reflects strong executive functioning and structured sequencing shifting tasks with relative vulnerability when working memory load increases or distractions are present. The D-KEFS color word interference test assesses inhibitory control, cognitive flexibility, and processing speed across 4 conditions: color naming, word reading, inhibition, and inhibition/switching. Patients' performance on the color word interference test reflects intact processing speed and basic reading efficiency, with relative inefficiency as inhibitory and cognitive flexibility demands increase. On color identification, patient performed in the high average range, 84th percentile rank, indicating efficient visual scanning and rapid color naming. Performance on word identification was also in the high average range, 84th percentile rank, reflecting well-developed automatic word reading and intact processing speed for overlearned verbal material. Performance on the inhibition condition fell within the average range, 63rd percentile rank, suggesting adequate ability to suppress automatic responses when required to engage controlled processing. This indicates that patient is generally able to inhibit dominant responses, though the skill is not a relative strength compared to her baseline speed. The inhibition switching condition was also in the average range, 37th percentile rank, reflecting the increased efficiency when the task required simultaneous response, inhibition, and mental set shifting. This pattern suggests that patients' performance declines as executive demands increase, particularly when inhibitory control and cognitive flexibility must be engaged concurrently. Overall, these results indicate strong foundational processing speed and reading efficiency with adequate but less efficient, high-order executive control under complex task demands. The Wisconsin card sorting test evaluates executive functions, including abstract reasoning, cognitive flexibility, problem solving, and the ability to shift cognitive sets and respond to changing contingencies. Patients' performance on the Wisconsin card sorting test reflects intact to strong abstract reasoning, cognitive flexibility, and problem solving abilities, with no evidence of clinically significant perseveration or set maintenance difficulties. Patients successfully complete all 6 categories greater than 16th percentile rank, indicating effective concept formation and the ability to infer and apply abstract sorting principles. The number of trials to complete the first category, greater than 16th percentile rank, suggests adequate initial hypothesis, testing, and learning efficiency. Additionally, failure to maintain set was not observed, greater than 16th percentile rank, indicating consistent adherence to established sorting rules once learned. Error analysis further supports intact executive functioning. Total number of errors fell in the high average range, 75th percentile rank, reflecting efficient problem solving with relatively few errors overall. Perseverative responses, 84th percentile rank, and perseverative errors, 81st percentile rank, were also in high average range, indicating good cognitive flexibility and ability to shift strategies appropriately in response to feedback. Non-perseverative errors were in the average range, 66th percentile rank, suggesting typical levels of random or non-systematic errors. Emotional/personality functions. The Beck inventories are face-valid measures of depression and anxiety. On the Beck Depression Inventory 2, patient's score of 3 placed her in the minimal range of depression, endorsing symptoms of sadness, loss of energy, and concentration difficulties. On the Beck Anxiety Inventory, patient had a score of 33 that placed her in the severe range of anxiety. Patient reported being severely bothered by the fear of the worst happening and fear of losing control. She also reported being moderately bothered by feeling hot, being unable to relax, feeling dizzy/lightheaded, feeling unsteady, feeling terrified and nervous, her hands trembling, feeling shaky, indigestion and sweating, not due to heat, and being mildly bothered by numbness/tingling, being unable to relax, her heart pounding/racing, difficulty breathing, a fear of dying, feeling faint, and her face being flushed. The Adult ADHD Self-Report Scale, ASRS, is a self-report screening tool designed to assess symptoms of attention deficit hyperactivity disorder, ADHD, in adults, based on DSM criteria. It includes questions targeting inattentive and hyperactive impulsive symptom domains over the past 6 months. Patients' responses on the ASRS Feed 1.1 indicate very high levels of self-reported ADHD symptoms consistent with significant attentional and executive functioning challenges in daily life. On the Criterion Part A scale, which captures captures core inattentive and hyperactive/impulsive symptoms, patients scored 20 out of 24, placing her in the 99.2nd percentile rank, very high. This suggests that her experiences of inattention, distractibility, and hyperactivity are substantially greater than those of her same-age peers. The additional symptoms, Part B scale, which assesses related ADHD features including disorganization, emotional dysregulation, and executive difficulties, were also elevated at 34 out of 48, 97th percentile rank, very high. This indicates that patient experiences broad and impactful challenges associated with ADHD beyond the core symptom domains. Overall, patient's total score of 54 out of 72, 98.5th percentile rank, very high, underscores the pervasiveness and severity of ADHD-related difficulties in her daily functioning. The Wonder-Utah Rating Scale for Attention Deficit Hyperactivity Disorder is a retrospective self-report questionnaire designed to assess the presence and severity of childhood symptoms consistent with Attention Deficit Hyperactivity Disorder, ADHD. Patients' responses on the Wonder-Utah Rating Scale indicate very high retrospective childhood ADHD symptomology, with additional innovations in emotional and behavioral domains. The total score was 74, 99.99th percentile rank, very high, reflecting pervasive and severe ADHD-related behaviors in childhood as recalled by patient. This is consistent with a strong historical profile of attentional difficulties and executive functioning challenges. Subscale scores reported further detail in the pattern of childhood difficulties. On the disruptive mood/behaviors subscale, patients scored 36, 99.99th percentile rank, very high, indicating frequent mood dysregulation and oppositional or challenging behaviors during childhood. The inattentive hyperactive subscale score was 21, 99.3rd percentile rank, high, reflecting substantial difficulties with attention, hyperactivity, and task persistence. The depression anxiety subscale was also elevated at 16, 99th percentile rank, very high, suggesting notable emotional distress in childhood, including feelings of anxiety or depressive symptoms. Overall, patient's WURS profile indicates marked childhood ADHD symptoms across attentional, behavioral, and emotional domains, consistent with the developmental history of ADHD. Patient completed the self-report form of the Behavior Rating Inventory of Executive Function, 2nd edition, adult version, brief 2A. Validity skills were all in acceptable range, with the exception of negativity scale. The negativity score is elevated, suggesting either that patient's view of herself may be excessively negative or that she may have significant executive dysfunction. As such, these results will be reviewed with caution. The overall index score, the Global Executive Composite, was highly elevated, greater than 99th percentile rank. The Behavior Regulation Index, BRI, Emotional Regulation Index, ERI, and Cognitive Regulation Index, CRI, scores were all elevated, BRI greater than the 99th percentile rank, ERI greater than 99th percentile rank, CRI greater than 99th percentile rank, suggesting self-regulatory problems in multiple domains. Concerned to know with her ability to resist impulses, be aware of her functioning in social settings, adjust well to changes, react to events appropriately, get going on tasks and activities, independently generate ideas, sustain working memory, plan and organize her approach to problem solving appropriately, and keep materials and belongings reasonably well organized. The Personality Assessment Inventory was completed by patient. Patient's PAI profile is considered invalid due to elevated negative impression score of T-110. Score at this level suggests a tendency to present oneself in an exaggeratedly negative manner, which may reflect conscious or unconscious over-reporting of problems, efforts to appear impaired, or extreme self-critical responding. Because the NIM scale is well above the interpretive threshold, overall clinical scores and subscale elevations cannot be reasonably interpreted. Any patterns observed on the PI may be influenced by response bias, rendering conclusions about personality traits, emotional functioning, or system severity uninterpretable in a meaningful clinical context. The Autism Spectrum Quotient, AQ, is a self-report questionnaire designed to assess autism-related traits in adults, including social functioning, attention to detail, communication, and cognitive flexibility. Patients' performance on the AQ indicates pronounced traits associated with autism spectrum conditions, with elevated scores across nearly all domains. Her total score was 42 out of 50, 99.98th percentile rank, pronounced. Scores reflecting a high level of autism-related traits relative to same-age peers. Domain-specific scores further clarify the profile. On social skill, patients scored 8, 99.1st percentile rank, pronounced, indicating notable challenges in social reciprocity, understanding social cues, and engaging in typical peer interactions. Attention switching was maximally elevated at 10, 99.93rd percentile rank, pronounced, suggesting a significant difficulty with cognitive flexibility and shifting focus between tasks or activities. Attention to detail was also elevated at 10, 97.9th percentile rank, pronounced, reflecting a strong tendency towards focused, detailed, or systematic processing. On communication, patients scored 99.97th percentile rank, pronounced, indicating challenges in expressive or pragmatic communication, including understanding conversational nuance. The imagination subskill was lower at 5, 94th percentile rank, consistent with autism, presenting some preserved flexibility, imaginative or creative thinking. Overall, patients' IQ profile demonstrates a pattern of pronounced autism-related traits, particularly in the social skill, attention to detail, and communication, consistent with an individual on the autism spectrum. CAT-Q is a self-report questionnaire designed to assess the extent to which individuals on the autism spectrum engage in social camouflaging, including strategies to compensate for, mask, or assimilate autistic traits in social contexts. Patients' total score on the CAT-Q was 162 out of 175, 97.3rd percentile rank, extremely high, indicating pronounced tendency to employ social camouflaging strategies. Subskill scores further clarify this profile. On the compensation subskill, patients scored 57, 97.1st percentile rank, extremely high, reflecting frequent use of strategies to actively compensate for perceived social difficulties. On masking, she scored 53, 97th percentile rank, extremely high, indicating that she often hides or suppresses natural autistic behaviors to conform to social expectations. On assimilation, patients scored 52, 92nd percentile rank, extremely high, suggesting a strong tendency to blend in and imitate peers to avoid social detection of autistic traits. Overall, patients' CAT-Q profile indicates extensive use of social camouflaging strategies consistent with individuals who are highly aware of social norms and expectations, but experience challenges in naturally navigating social interactions. These tendencies may contribute to heightened cognitive load, social fatigue, and stress, despite often appearing socially competent in structured or familiar environments. The empathy quotient is a self-report questionnaire designed to assess cognitive and affective empathy, including the ability to recognize, understand, and respond to the emotions of others. Patients' total score was 14 out of 80, 0.65th percentile rank, extremely low, indicating markedly reduced self-reported empathy relative to same-age peers. The score suggests significant difficulty in recognizing and responding to others' emotional states, which may impact social interactions, perspective-taking, and interpersonal understanding. Overall, this profile aligns with other self-report and performance-based measures indicating pronounced autism-related traits and social processing challenges, and may contribute to difficulties in navigating social situations despite cognitive or verbal strengths. The Obsessive-Compulsive Inventory Revised, OCI-R, is a self-report questionnaire designed to assess obsessive-compulsive symptoms across multiple domains, including checking, ordering, washing, hoarding, and neutralizing behaviors. Patients' total OCD score was 59, 99.9th percentile rank normative, indicating extremely high levels of self-reported obsessive-compulsive symptoms relative to both general population and clinical norms. This score suggests significant intrusive thoughts, compulsive behaviors, or ritualized patterns that may cause distress or interfere with daily functioning. On the hoarding disorder subscale, patients scored 7, 99.6th percentile normative, suggesting that hoarding behaviors are not a clinically meaningful concern and do not contribute substantially to her overall OCD symptom profile. Overall, patients' OCI-R profile indicates pronounced obsessive-compulsive tendencies, particularly in domains other than hoarding. These findings are consistent with elevated anxiety, perfectionism, or cognitive rigidity. It may interact with attentional or executive functioning challenges to affect daily performance and psychosocial functioning. Summary and impressions. Patient is a 19-year-old transgender female with long-standing history of neurodevelopmental, emotional, and behavioral concerns, referred for neuropsychological evaluation to clarify diagnostic presentation and inform treatment planning. There is a strong family history of autism spectrum disorder with both parents and two cousins formerly diagnosed, and a prior therapist also expressed significant concern for ISD. Since early childhood, patient has expressed social communication difficulties, restricted and highly focused interests, repetitive behaviors, and marked sensory sensitivities, particularly to sound and tactile stimuli. Sensory overload often results in the need to withdraw from the environment and engage in self-regulatory behaviors. She also reports long-standing feeding selectivity and with a limited range of safe foods, and prior clinician raised concern for possible avoidant restrictive food intake disorder. Patient additionally endorses significant executive functioning and attentional difficulties consistent with an inattentive presentation of ADHD, including impaired task initiation, decision-making anxiety, and avoidance of sustained mental effort. She reports prominent obsessive-compulsive symptoms characterized by intrusive, ego-dystonic thoughts and compulsive rituals driven by a need to prevent perceived harm. Mood-related concerns include chronic irritability and depressed mood, as well as episodic periods of elevated or expansive mood associated with decreased need for sleep, impulsiveness, reduced sleep inhibition, social inhibition, and risk-taking behaviors. Sleep patterns have been chronically erratic, with fluctuations in sleep duration that may correspond to mood changes. Psychosocially, patient performed well academically and participated in enrichment programming but reports feeling targeted in school due to being the youngest in her grade. She completed 1 year of college before taking a gap year and plans to resume her education internationally in fall 2026, majoring in sound for theater. She's currently working in delivery services and has a temporary driver's license suspension related to a recent traffic violation. She's not currently engaged in mental health treatment, though she has a history of psychotherapy and psychiatric care and reports past passive suicidal ideation. Current medications include estradiol and spironolactone. On neuropsychological testing, patient demonstrated valid and reliable effort on neuropsychological testing, including performance validity measures and the MOXO CPT, supporting confidence that her results accurately reflect her current neurocognitive functioning. Her intellectual profile is uneven, with exceptional strengths in verbal reasoning and crystallized knowledge, verbal comprehension index in the exceptionally high range, 99th percentile rank. Nonverbal reasoning, visual spatial skills, working memory, and processing speed fell in the average to high average range, with variability across subtests. Notably, auditory attention span, digits forward, was an area of exceptional strength, whereas tasks requiring mental manipulation, digits backwards, were relatively less efficient. Due to large discrepancy amongst index scores, the full IQ scale was not interpreted, and emphasis was placed on the pattern of individual cognitive strengths and weaknesses. Assessment of education and executive functioning revealed a mixed profile. On the MOXO CPT, patient exhibited reduced sustained attention and slowed response speed, suggesting challenges with maintaining focus and responding efficiently under time-constrained conditions, though impulse control and behavior regulation were intact. Executive functioning tasks demonstrated strong sequencing, set shifting, and cognitive flexibility under structured conditions, D-KEFS verbal fluency, trail-making color interference, Wisconsin card sorting test, with relative inefficiencies emerging under increased working memory demands. When inhibition and flexibility were required simultaneously. This pattern suggests that patient can perform complex tasks effectively when demands are clear and structured, but efficiency declines under high cognitive load or distraction. Self-report measures provide further context for a patient's cognitive and behavior profile. She endorsed very high current ADHD symptoms, ASRS, and marked retrospective childhood ADHD behaviors, WURS, including inattention, hyperactivity, and executive difficulties. She also reported significant anxiety symptoms, Beck Anxiety Inventory, and minimal depressive symptoms, Beck Depression Inventory, consistent with her neuropsychological profile. Patient reported pronounced autism-related traits, AQ, and extensive use of social camouflaging strategies, CAT-Q, alongside markedly reduced empathy, EQ, indicating challenges in social cognition and interpersonal understanding despite strong verbal reasoning. Obsessive-compulsive tendencies were elevated, OCIR, although hoarding behaviors were not clinically significant. The Personality Assessment Inventory, PI, was invalid due to highly elevated negative impression scale, limiting interpretability of personality or emotional functioning on that measure. Patient's evaluation reveals a complex, multi-determined neuropsychological and psychological profile consistent with co-occurring neurodevelopmental and psychiatric conditions, including attention deficit hyperactivity disorder, combined presentation, autism spectrum disorder, avoidant restrictive food intake disorder, ARFID, a severe anxiety disorder, and obsessive compulsive features. Her WAIS-5 profile demonstrates exceptional verbal reasoning ability alongside more variable performance in working memory, processing efficiency, and mental manipulation, a pattern commonly observed in individuals with ADHD and autism. Performance-based measures of attention executive functioning, MOXO, D-KEFS, WCST, further supported efficiencies in sustained attention, response speed, and cognitive load tolerance, with preserved higher-order reasoning, set shifting, and problem-solving under structured conditions. Self-reported measures strongly corroborate these findings. Patient endorsed very high levels of current and childhood ADHD symptoms, ASRS V1.1, WRS, pronounced autism-related traits, autism spectrum quotient, extensive use of social camouflaging strategies, CAT-Q, and markedly reduced empathy, EQ, all of which are consistent with autism spectrum presentation, particularly in high-masking individuals. Anxiety symptoms were severe and pervasive. Obsessive-compulsive symptoms were extremely elevated on the OCIR, reflecting clinically significant intrusive thoughts and compulsive behaviors, although the PI was invalid due to markedly elevated negative impression management scale, T-110. The breadth and consistency of data from other instruments provide a robust basis for diagnostic formulation. Importantly, patient's history includes clear evidence of restrictive eating accompanied by significant weight loss, approximately 40 to 50 pounds during the latter portion of the COVID period, nutritional deficits, and functional impairment, which meets diagnostic criteria for avoidant restrictive food intake disorder, ARFID. These eating difficulties appear to be sensory and anxiety driven rather than weight or shape motivated and are best understood within the broader context of autism related sensory sensitivities, rigidity, and heightened anxiety. Differential considerations include bipolar disorder and borderline personality disorder. However, the available data do not support these diagnoses. There is no evidence of discrete manic or hypomanic episodes, and emotional lability is more parsimoniously explained by ADHD, autism, anxiety, and the effects of chronic stress. Additionally, the invalid PI precludes reliable assessment of personality pathology, and there is insufficient evidence or pervasive identity disturbance, interpersonal instability, or self-harm behaviors characteristic of borderline personality disorder. Diagnosis and recommendations. My diagnostic impressions of patient using ICD-11/DSM-5-TR classifications are offered within a reasonable degree of neuropsychological and psychological scientific certainty as follows. Autism spectrum disorder, F84.0. Attention deficit hyperactivity disorder, combined presentation, F90.2. Generalized anxiety disorder, F41.1. Obsessive compulsive disorder, F42.9. Avoidant restrictive food intake disorder, F50-82. Bipolar disorder, provisional. Based on the evaluation findings, the following recommendations are provided to support patient in managing her symptoms effectively across different settings. Patient reports severe anxiety and obsessive compulsive tendencies, which can further exacerbate attentional and executive functioning difficulties. It is recommended that she actively engage in ongoing therapy with a focus on evidence-based interventions targeting anxiety and OCD. Cognitive behavioral strategies, including exposure and response prevention, cognitive restructuring, and mindfulness techniques may help her develop coping skills and reduce functional impact. As she is not currently under the care of a medication provider, it is also recommended that she consider psychiatric or advanced practice evaluation to determine whether pharmacological support may be indicated for anxiety-related symptoms, ensuring a comprehensive multidisciplinary approach to her care. Patient reports a history of chronic irritability and depressed mood, as well as episodic periods of elevated or expansive mood, characterized by decreased need for sleep, impulsiveness, reduced social inhibition, and risk-taking behaviors. Sleep patterns have also been chronically erratic, with fluctuations in sleep duration that may correspond to these mood changes. While these features raise question of possible bipolar spectrum or cyclothymic conditions, the current evaluation does not provide sufficient evidence to meet full DSM-5 criteria for a formal bipolar disorder diagnosis, including clear duration, intensity, and functional impairment of hypomanic or manic episodes. Mood lability may be alternatively explained by ADHD, anxiety, and autism-related emotional dysregulation, which are well supported by performance-based and self-report measures. Given these reports, it is recommended that patient receive psychiatric follow-up for comprehensive mood assessment, ideally including a structured interview or longitudinal mood tracking to clarify the presence, frequency, and severity of any manic or hypomanic episodes. At this time, bipolar disorder is considered a differential diagnosis, and ongoing monitoring is warranted, but is not included as a primary diagnosis in the current evaluation. Given patients severe anxiety and obsessive compulsive tendencies, as well as her significant attentional executive functioning challenges related to ADHD, it is recommended that she consider evaluation by a psychiatrist or advanced practice nurse, APN, to determine whether pharmacological intervention may be appropriate. Medication management could help optimize attention, reduce anxiety, and support emotional regulation, particularly in combination with ongoing therapy and behavioral strategies. This evaluation would allow for a comprehensive, individualized approach, integrating both therapeutic and potential medical interventions to support daily functioning, academic performance, and overall well-being. Patient demonstrates uneven cognitive abilities with exceptional verbal reasoning, average to high average nonverbal reasoning, and relative weaknesses in working memory, mental manipulation, and processing speed. To support academic performance, accommodations such as preferential seating, reduced distraction environments, and written or visual instructions are recommended. Breaking complex assignments into smaller, manageable steps, providing extended time for tests and assignments, and regular check-ins with teachers or support staff can help compensate for attentional challenges and processing speed limitations. Use of graphic organizers, checklists, and explicit scaffolding may support working memory and executive demands during multi-step tasks. Patient shows difficulty sustaining attention and slow response speed under unstructured or time-constrained conditions, alongside strong executive functioning when tasks are unstructured. Classroom supports such as frequent monitoring, guided transitions, and prompts for task initiation and completion are recommended. Interventions targeting organization, planning, and cognitive flexibility, including the use of planners, visual schedules, and structured routines, may help manage complex assignments and daily responsibilities. Patient exhibits pronounced autism-related traits, social camouflaging, and reduced empathy, which may contribute to social fatigue and stress. Social skills support and coaching and perspective taking, pragmatic communication, and peer interaction strategies may be beneficial. Opportunities to practice social skills in low pressure or restricted environments, as well as explicit guidance on self advocacy and managing social expectations, are recommended to enhance social confidence and reduce anxiety related to social performance. Almost done. To address the cognitive load from social camouflaging anxiety, patients may benefit from scheduled breaks, stress reduction strategies, and sensory-friendly environments, particularly when working on complex tasks or engaging in prolonged social interactions. Encouraging healthy routines, sleep hygiene, and structured daily schedules can help support overall functioning and mental health. Regular follow-up is recommended to monitor academic progress, executive functioning, and emotional well-being, and to adjust interventions as needed. Coordination between school staff, therapists, and medical providers will help ensure consistent support across settings and allow for timely identification of emerging challenges. These recommendations aim to support patient in managing her symptoms effectively and improving daily functioning across occupational and personal settings. Regular follow-ups with healthcare professionals are encouraged to monitor progress and adjust interventions as needed. The above-cited opinions are referred within a reasonable degree of neuropsychological and psychological scientific certainty based on all the information available to me at this time. I reserve the right to amend these opinions if additional information is received. Please do not hesitate to contact me with any questions. Sincerely yours. Bye.